Thank you, Dr. Helen, for the kind introduction. And it's me again, pharmacist from IMH. Now we are talking about depression and about the medication used in depression. So first thing, overview, again, like what is the objective of the treatment, when to treat, which one to choose, what to watch out for, concurrent use with benzodiazepine, how long to treat for, how to treat the antidepressant, augmenting, and about discontinued antidepressant. So from the slide, I think you'll know my sharing will be a lot overlapping with what Prof. Lim has said just now. So I'll go through it very briefly and quick. Yeah, so first thing, what's the objective for the treatment? Yeah, before we start therapy for the patient, obviously we need to have the objective in mind, like what we want to achieve for this patient. So very important, symptomatic remission to get patient out of depression and to restore their function in occupation or in the society, and also to reduce the likelihood of relapse or recurrence. So when to treat, it really depends on the severity of the depression. It's indicated for moderate to severe depression. And mild depression, usually if it's more than 2 to 3 months, then we start antidepressant. And because usually the mild depression, it may improve spontaneously over time, or it actually responds to psychosocial intervention. So which antidepressant to choose? My table is gone. Okay, yeah. Sorry, table doesn't come up. Yeah, so the comparison among the between the SSRI and TCA or MAOIs, as we know in the past, TCA, MAOI, they were the first line. Then with the SSRI now, SSRI is the first line. Is it because of SSRI better than the TCA in terms of efficacy, or why is SSRI so popular nowadays? As compared to the efficacy, actually they are the same. They're similar among the SSRI itself or between the group of SSRI or TCA or MAOIs. Studies have shown that the efficacy, there's no significant difference in terms of efficacy. However, SSRI become the first line is because of the risk-benefit ratio is actually higher than TCA in terms of tolerability, safety in overdose. Yeah, you overdose, you take 10 tablets of SSRI, still could be safe compared to if you take 10 or 20 of TCA. Yeah, and also the concurrent CVD cardiovascular disease, SSRI is also favorable compared to TCA. Yeah, then okay, then the alternative for the antidepressants, we have other different groups, SNRI, venlafaxine, duloxetine, NASA, mirtazapine, Remeron, NDRI, bupropion, agomelatine. So all these antidepressants, how do we choose? So same thing, take into consideration the patient's history, the response, the side effect history, and also concomitant medical or medication that patient is taking currently because of the drug interaction, and also the cause and patient's preference. Okay. Yeah, so from here, maybe we can zoom in the physical health condition. So if we have a patient who having cardiac disease, we want to avoid TCA. If we have a patient who is also having some sexual dysfunction, so which one do we avoid? Or which one is our choice of antidepressant for this group of patients? Any idea? Do we still give SSRI for this group of patients who have maybe ED? No response. Yeah, if we have patients with sexual dysfunction, SSRI is the first thing that we really want to avoid because it's one of the common side effects for SSRI in sexual dysfunction. And the choice of the antidepressant for this group of the patient will be bupropion, Wellbutrin, or Zyban. Okay, if we have a patient who also want to quit smoking, So bupropion will come into place again. Yeah, so with bupropion, one stone kill two birds. We have the patient with smoking and also have the patient with depression. Okay, then and also if we have patient low BMI, low appetite, cannot sleep, which one is the choice from all the antidepressants? Any guess? Okay, mirtazapine. Yeah, mirtazapine is associated with weight gain, and the mechanism has been hypothesized as increased appetite. Yeah, so if we have a patient very low BMI, cannot sleep, maybe if cost is not an issue, yeah, maybe mirtazapine would be the choice. Okay, then some other example like presence of interacting drugs. Escitalopram and sertraline would be the preferred one because of the metabolism of these two drugs. They are less involved in drug interaction. The cytochrome, the CYP2D6, they are less involved in that. So, what about if we have a patient also on antiplatelet or anticoagulant like warfarin? Do we give fluoxetine or fluoxamine? Yeah, I see a shaking head there. Yeah, we will try to avoid SSRI if we patient on antiplatelet or anticoagulant because SSRI increases the risk of bleeding. Also, we have serotonin receptor on our platelet as well. So SSRI also work on that one. It's not so selective. But if you really want to give a SSRI, would be the preferred one, escitalopram. Okay, if we really want to give a SSRI for patients who are on antiplatelet or anticoagulant warfarin, escitalopram would be a preferred choice. But if patient also on warfarin, INR monitoring is a need lah. Okay, and if I don't want to give SSRI, is there other alternative? If I have patient on antiplatelet, anticoagulant, then patient at risk for cardiac disease also. So TCA, is it a choice? No. How about mirtazapine? Yeah, mirtazapine would be an alternative for patients who also at risk of bleeding. Okay, yeah. So there are some examples for the choice of antidepressant for patients who have concomitant medical condition or medications. Okay, so what to watch out for? Yeah, we all know suicidal thinking and changes in behavior. This one especially during the early treatment when we first started patient on antidepressant, and some even when we increase the dose of the antidepressant, we might warn the patient about this suicidal thinking or changes in behavior also, especially if our children, our patients are children, adolescents or young adults, 18 to 24 years old. So how do we warn the patient? Tell the patient, if you take this one and you have suicidal thoughts, you come back. Or this one may make you to have suicidal thoughts. So how? Or do we avoid this suicidal thoughts discussion with our patient at all? So usually for us pharmacists, when we dispense antidepressant for the patient and we know that they are first started on it, a recent change in the medication, in the dosing, and especially for this group of patient, young adults, we'll tell the patient, beside the normal side effects, blah, blah, the expectation from the antidepressants, we'll tell the patient about, we put it in this way, if over these few weeks, before you see a doctor during your TCU, if you have you have a thoughts of harming yourself or harm other people, or you find yourself not yourself, then you'll come back early to see the doctor, get an appointment earlier, or go to A&E immediately. Yeah, and if the patient come with the family caregiver, that would be best. Tell the caregiver about this thing and ask them to watch out to help to monitor the behavior of the patient. Because sometimes the patient, they may not know there is a behavior change in themselves. So caregiver really play a role. So when we discuss antidepressant with the patients, we discuss with the caregiver as well.